Healthcare World with Harvinder Narula. Continuing on our conversation on patient safety as a part of BW Healthcare World series with Kaho, we have with us today Professor Nadira Chaturvedi, who serves as a co-chair of Patients for Patient Safety Foundation. As an academician and a social entrepreneur, she holds an MBA from Indian Institute of Management, Ahmedabad, and has 40 years of experience. And additionally, for the past 15 years, she has served as a professor of business studies. Demonstrating a commitment to social development, she has actively contributed to projects focusing on the health and education of the underprivileged and marginalized sections of our society for over 17 years. Welcome, Professor Nadira Chaturvedi, to BW Healthcare World.
Thank you, Mr. Narula. It's a pleasure to be here and a privilege to talk to you.
It is indeed, ma'am. Thank you so much for taking our time. Professor Nadira, can you explain what is the essence of patient engagement and its importance in the field of healthcare?
Patient engagement, one of my favorite words these days. Thank you for that prompt. There are two words here, patient and engagement, and I think they are not yet connected in the healthcare industry. The healthcare industry is doing a tremendous job. We got into this business of health and safety just 2 years ago. And our introduction to the various doctors, nurses, the care facilities, administrators was very enlightening. There is a lot of work happening, a tremendous amount of technology, predictable genetics, cutting edge stuff going on. And they are really, really employing all the skills possible, including research and reviews, for patient welfare. They look for two things, basically, clinical outcomes and patient experience. This is what they aim at. While we noticed the work that is being done, there was one piece missing. They are doing everything for the patients, but they're not doing it with the patients. So to us, patient engagement, the second word, means kindly involve the receiver of the care in this whole process, because anyway they're dedicated, but the engagement is missing. When I mean engagement, I mean it's a two-way process. You don't just tell people, you don't just do for people, but you also listen, you involve, and you see what suits and what is applicable to your audience. That becomes engagement. So it's a two-way thing, and both ways, the healthcare would benefit as well as the patients would benefit. It's a two-way process, as I mentioned. So what is missing is the communication, according to me, or rather it's incomplete. It's not missing, it's incomplete, or it's just one way. To be honestly, on behalf of the healthcare, I would also say patients themselves do not engage with the doctors and the providers of care. We treat them as God. We treat them as, we can't voice it. We can't, it's like a Bible. It's the truth. It's true. They are looking after us. But do we also engage in our own care? Do we engage as involve ourselves, or we just surrender that this is God's will? Of course, it's God's will, but God manifests itself in the form of doctors and in the form of caregivers. So I think engagement is both ways, and that's where the change is going to happen, and we are working on that change.
Absolutely. And Professor Chaturvedi, what happens is that sometimes we are unable or are not inclined to take a feedback that helps us evolve. So I think that is something which needs to be taken care of when it comes to the healthcare industry. Now,
absolutely.
How does patient engagement, in your opinion, contributes to enhancing the quality of patient care that a patient can expect to receive in an institution?
Absolutely. I think this is an important part, and more than the healthcare, patients need to understand, people need to understand, caregivers need to understand this question that you asked. It's very, very pertinent, and we're working really hard on this aspect. When we go to the doctor, we fall sick, and I'm going to widen this range. I'm not going to say when we go to the doctor. The tenure of this treatment or the tenure of this broadband has come before we go to the doctor, during our treatment, and also when we come back. So at all these three stages, if we are aware that we need to go, if you're aware of the symptoms, if you're aware of the possibilities of the risks, if you're aware of the consequences, maybe we would take steps much earlier. So when you get engaged and when you get aware, you do an earlier response or an earlier checkup on that. When you go to the doctors or when they prescribe something, you're not convinced, you ask questions. You're convinced, you follow the treatment. You feel he's not good enough, you don't have the trust, and then you discontinue the treatment. And in the end, you blame the doctors, you blame the people who provided the care. Even in the end, when the transition to your home comes back, and I think 95% of our care is being done in the house. So that zone is completely obliterated, completely eliminated by the doctors because they see only what is happening in their facilities. So I think the 95% of areas are unlooked at, they're not looked at, they're not bothered about. And problems happen in all these three zones. So if I may say, yes, the healthcare is doing something, but they're doing it in the 5% of the journey, patient journey, as we call it. But the rest of it, if we knew what causes harm, what causes errors, what causes safety, and if we were taught to look after us, I think both would benefit and we would have less recurrences, less number of days, less relapses and visits to the doctors again. So I think that would be a big benefit. Ultimately, but why should the doctors do it? Why should the healthcare do it? They don't have the time. There's enough patients. There's enough of a queue. The OPDs are full everywhere. The point is that when a person, a sick person or a family is satisfied and they tell 4 other people, if they're not satisfied, they tell 10 other people. These were the statistics, actually that were determined by a large hospital chain. The good points you multiply 4x, but the bad points you multiply 10x. So if you have a positive cycle going on, you will get more referrals. You will get more loyal patients. We'll all fall sick. We'll all grow old. There'll be somebody else falling sick, and you want a good, decent place to go to. And that translates into a larger patient base, a larger money base, and profits for the organization. So actually, it's a win-win situation. The patient is satisfied and the hospital is earning money.
Right.
So both are earning it.
And Professor Chaturvedi, how is Patients for Patient Safety Foundation contributing towards patient engagement? What is it that you are doing which is helping the industry?
I'll give you a real example. I was interacting with a group of cancer patients. They were from the lower economic strata, and we interact with them periodically through another NGO that I'm associated with. And I was taking a session and I said, how are you all? And they were very delighted. They thought this madam has come and she's going to cure us all. So they started opening up their packets, their bags, and they started taking out the papers. There was yellow stained, samosa stained, tea stained, doesn't matter because they live on the streets, they live on the rain baseras. But it took them about 7 minutes to get their papers out or in order. And most of them didn't have their reports. Some of them had lost the prescription. Some of them had given it away to the nurse. So I realized that, my goodness, even keeping a medical records in chronological order, keeping them all in one place, that basic skill which we take for granted is missing. So we explored more literate audiences and we speak to so many people in our outreach programs. And everybody is silent when we ask them, do you have your records in one place? So the basic things what Patient Foundation is doing is giving back to society, giving back to patients, the basic skills you need to enable a doctor to do his job faster, better, quicker, and easier. For example, rights and responsibilities. For example, what should you do to prevent diagnostic errors? Early reporting of symptoms, taking up all the tests. The mistrust is there, I know, but because of that trust, you don't cut your nose to spite your face. And you doubt whether this test is important, whether the doctor is making money. When you do an X-ray and then he says, come back and do an MRI, and then he says, come back and do a CT scan, you say, oh, this person is just making money. But there is a chronological order of investigation, which we don't understand. And this is what we are explaining to the people at large in simple words: infection control, preventive health, women's health at different stages. Nowadays, it's mosquito season. How do you prevent it? So we are doing prevention. We are showing symptoms. We are showing early detection. We are not giving clinical advice, but we are telling the person when you should seek advice, when you should prevent yourself, and the risks if you don't do it, the consequences if you don't do it. So I think our work is a very niche. It is part of the wellness program, but it's not just eating 5 almonds a day or an apple a day keeps the doctor away. It's perhaps much deeper than that, much sharper than that. And while the doctors take an oath when they pass out in the Hippocrates Code, the first line is do no harm. But patients do not have that oath. And we also do harm. So we are highlighting these areas and illuminating the general public in multiple ways, reaching out through multiple partners. And I think, thank you for being a partner right here. You are a patient ambassador who would take the voice, our voice, to the masses. And we have text versions, we have graphical versions, we have audios, we have videos, we have mailers, we have subscriptions. Everything is on our website. So it's a multimedia. The world has changed. Technology is here. Let's use that. We have a smartphone. Let's be smart enough to use that. That's what we're doing.
And Professor Nadira, I must tell you this, that I'm writing a book which is going to be published in about a month or two. It is called Defeating Cancer. And I've studied the behaviors of the patients. And we've realized that, apart from the doctor and the medicine that they're receiving, there's a huge role that the patient plays in their own recovery, which could be faster if they wish they had, if they're informed and they wish to.
Absolutely.
So, that is extremely important. Now, next thing that comes to my mind is that, I understand the objective of Patient for Patient Safety Foundation, but what can you explain some of the initiatives that you've taken at the national level to facilitate the patient engagement? What is it that the foundation has done?
See, as we mentioned, our first job was when we saw the healthcare industry and the professionals. We said we can't take codes to Newcastle and we can't teach them what to do. Although I'm saying that now, but maybe a little later we might enter that zone. But in the beginning, we had to build trust and we had to learn from them, and we continue to learn. We've got access to several experts thanks to CAHO, who has sponsored our organization. While CAHO works with the healthcare professionals, we are working with the people. So our first job, therefore, was we turned around this whole thing, and I think this was unique in our foundation. We said, let's not teach them what they already know. Let's teach ourselves. Let's turn the bag inside out and learn what we need to learn, reinforce our beliefs, reinforce our role, not just rights, not just responsibilities, but our role in our healthcare. So the entire orientation, and this is unique. I have seen many sites, and there are many other patient safety foundations in the US, in Malaysia, in Canada, very good ones. But again, they're just advocacy or they're doing. But nobody is educating a patient. And that's what we are doing. I think that is our fundamental pillar. We've got 3 pillars, and that is one of our first pillars. Creating suitable, simple, applicable, actionable orientation material for people before they fall sick, during their treatment, and after they get right. So our patient education or awareness material is one of the biggest things we're doing. And on a national level, you mentioned the things. We are trying to promote this through partners in the corporate sector, through partners in the civic association sector. So we talk to somebody, and then we hold webinars, and then we send out regular emails and posters and videos, etc. All our content is available. It's free, no commercials, and it goes to the wider masses. This is one thing for the private sector. For the healthcare sector, we've taken another initiative, and we are building up formulated strategic partnerships so that they can use our material, because our target is the same. The audience is patients. So initially, it took us time to build trust. Initially, it just worked. Within a year and a half, I think 2 years, they have come to believe that what we are talking makes sense to them. And we are building, and we present these in conferences, webinars, face-to-face interactions. And I think about 254, almost, I think now it's 400 hospitals want to use our material, and they can do it themselves. So this is another initiative. But on a wider level, we're also trying to push it in the research. So if they could research on the topics that are chronically, let's say, unsatisfactory to a patient, that might really help. So we are going on a multiple means, and we're also creating patient advisory councils as a strategic tool on a national level to enable and sustain what we are doing, because ultimately it's the healthcare that has to take this forward, and that's it. Then it'll be more effective.
But Professor Nadira, what happens is that healthcare is a need-based industry. When people think about it, only when they need the healthcare services or need help. Now, it is extremely important to be present where the patient goes when they need healthcare. So what is, I've heard that, you guys have patient advisory council. Can you explain what patient advisory council is and how can it be set up within the healthcare facilities? Because that's where the patient is going when there's a need arises.
You hit the nail on the head. Absolutely. So very early we realized that we may talk, we may speak, and then a common question we get is, but we have Google. We have Dr. Google. Why should we listen to you? What are you telling us which is new that we already don't know? And it took us time to answer that properly. And we said, yes, of course, Dr. Google is there. But when you have an emergency, when you're having a stroke, when you're choking, when you're burning, when you have an accident, do you have time to Google? You don't have time to Google. So in advance, the key word is that awareness before I need it is one of the things that we need, right? And that we are doing, as I mentioned, through private partnerships. But people don't read, people don't listen, and they don't bother unless it hits them. I mean, when you mention cancer, it hits me because I'm a survivor for the last 18 years now, by the grace of God. And I know exactly what you're talking about through support groups, how we improved. But if I tell a non-cancer person, go to this support group, why would they go? They don't need it. So, right. But we do listen when we are sitting in the OPD, when we are sitting in the wards, when we're waiting for our test reports, when we have nothing to do and waiting at the billing. So in the geography of a care facility, our eyes, our ears is more open. We may be anxious, but there are waiting periods where we can do it. And so we decided, or rather we suggested to Kaho that let's begin something which is a structured method of promoting our awareness. And that's where the seed was planted about 18 months ago of a patient advisory council. We didn't know it was happening in the world. Very soon we started learning. So a patient advisory or a patient and family advisory council is a structured process wherein there's a partnership, it's a voluntary process, but there's an advisory board with equal or kind of equal proportion of healthcare professionals and seasoned patients. It's not a blame forum, it's not a claim forum, it's nothing of that sort. And it's not somewhere you go in grievance forum either. You come together, discuss like mature adults, both listen, not talk, both listen first. And then you arrive at a short list or you prioritize a list of issues that are chronically problematic in a particular care facility. This would vary from facility to facility, region to region, demographics, and specialties. There's no one size fits all. But in a pragmatic, in a practical, and a mature manner, you decide, okay, this issue needs more work. And then you progress. Then you create, there's a whole structure. There are lots of steps which I could go on. I mean, maybe I'll explain that a little later. But then you come back with solutions and it doesn't end there. The solutions are again passed on to the general public and institutionalized within the care facility, within the trainings, whoever is delivering, whether it's physiotherapy, whether it's a dietitian, whether it's the nurse, or just the cleaning staff. And that's how you can get better and better and better, but with both perspectives. That is engagement coming into the forum. And why there? Because we listen to our doctors with all our ears. They still remain our gods. The hospital is still our temple for our bodies.
And Professor Chaturvedi, what is the role that Patient Safety Foundation is playing in promoting these PSAs?
So when we just say create a facility or create a board, it doesn't happen, right? So because of our, let's say, our collective experience of the team in the foundation, we made three things. We created a manual, we created a white paper, and we're doing hand-holding. Now, what is the meaning of this manual? What is the meaning of a white paper, which Kaho published? We said, how do you design, how do you structure, and how do you operationalize the complete PSA? I'll use the word pack here. So we decided there were three parts to this whole thing. The very first part, and this was our contribution to creating a document on which you can do the whole work. And this has been very well received. So the first part is the intent. It's a voluntary thing, but the intent of the hospital must be there. You have to sell it to the senior people. And because of that intent, you design a certain format. Maybe a hospital does more on hearts or BP or things that lead to the heart problem. Maybe a maternity hospital does more of neonatal care or postnatal care or maternal health care. So you design the forum, you design the number of people, you design the vision, and you design the end role, the key performance index. You also design how many people will be on that board, how many meetings you will have, and when and who will get access to the results of the meetings. So this is the designing area. The second section comes of actually operationalizing it, because everything, many people start with an intent and it's left behind. We all start hobbies and new resolutions, and they just stay a new resolution. But when you translate that into action, that's where the real key comes. So the induction of the healthcare representatives, the induction of the patient representative, it's very crucial to have the right person. He should be articulate. They should not be blaming. They should not be judgmental. And they should be not personal, anecdotal, but a voice of a larger community. So they bring experience and the sensibilities of the healthcare industry. I think it's an exchange. So the induction program, the requirements, the don'ts, not just the do's, but the don'ts, I think are very crucial in any successful implementation. And then the actual holding of the meetings, the reviews. A facilitator is required, a dedicated facilitator. It's not that I'm payable when able. That doesn't work. There has to be a primary job. They must report to the CEO. The CEO in turn must have group meetings and share the findings. So it becomes part of the KPI of the hospital. So then it gets operationalized. Again, we start, we do it, we don't feel rewarded, we leave it. So the third stage, sustainability. And that's where we created, you celebrate success. You present data. Don't just say it went well. 2%, 1%, 0.5%. For example, one hospital worked on discharge process. From 5 hours, they brought it down to 3.2 hours. Now that's something to talk about. It's a real figure. Infection control, secondary infections, recurring visits to the hospital. From 3 visits, you come down to 2.1, come down to 1.5. So when these metrics are presented back on the TV screens in a hospital, it actually creates a positive message. They should not be afraid. And success, reward the people. It's a multi-departmental groups that we make. So we're hand-holding the entire process so that there's a long-term impact and long-term acceptance of this whole concept. That's our contribution.
And Professor Chaturvedi, before I let you go, I'd love to understand how has been the response of a hospital to this? Because, like you said, they are used to being treated like gods, somebody that people look up to, and, they're used to just telling the patient to do whatever and there's a lot of acceptance at the patient level. So how are they accepting this concept of PACs, and are they participating? Are they responding to this?
So initially, there was a blank wall. There was a mistrust. In fact, I could see that, why are these people here? That kind of an expression. But very quickly, when they realized that we are partners, we are not adversaries, it took us time to convince them. We are on the same side. Our audience is the same. It's just that our route is different. And I would sum it up. When a doctor treats a person, he says, your health, my responsibility. But we are saying, my health, my responsibility. So we are really sharing the burden of the responsibility. We are building bridges of trust back to you. And you are the one who will continue to give it. And when they really saw the quality or the nature of the content that we are providing, I think the conviction got faster. And we were delighted that each time we have a conference, somebody comes up and says, ma'am, we've seen it. Sir, we've seen your material. We are using it. And many of this is being displayed not just in hospitals, but in clinics, OPDs, etc. Now, I must tell you, the large hospitals have a big ego. The large hospitals have a lot of resources. So maybe they do not use our material, but the mid-size, the small size, the rural, the distant, the tier 2, tier 3 are really happy that there is somebody who's talking the same language. See, the advantage here, one line is, as a doctor, you will meet 200 patients. You cannot give the same sermon 200 times. You give one sheet that we have prepared, it's standardized, but it's the same language. And we've converted everything into regional languages, by the way, all the 12. 2 in the north, 2 in the east, 2 in the west, 4 in the south. So we've got them all. And the same language, they don't have to repeat. It's there, ready. So the standardization of the message, of course, you customize it according to the person. But still, so they are benefiting. And now they are the ones who are saying, please help us to establish the facts. Which it begins with a grievance cell, it becomes with a feedback cell, but soon they understand that it's not just a feedback session, it's not just a grievance cell, and they widen and deepen their research. So they're benefiting.
I think this is really beautiful, Nadira ma'am. What really, I could take away as someone who could be a patient tomorrow is that you need to be informed before you need it. Unfortunately, nobody was doing this. I'm so glad that this foundation has come up and taken upon itself to go spread this message that, because what happens is if you are somebody who's informed, you can demand the quality of care that you are entitled to.
Absolutely, absolutely.
And make it obligatory for an healthcare institution to be able to serve you with that care. And if they're obligated to, and if the hospital is able to give you that care, coupled with the responsibility that the patient is aware of in terms of what is it that they need to do, I think, we could double up the speed at which the outcomes are getting improved every day. And I think that's my big takeaway. And I love the line that, my health, my responsibility.
Absolutely.
So,
you summed it up beautifully, because the two gaps were awareness on behalf of the patients and communication on behalf of the. I think our foundation is working on both these, creating awareness and building communication for both the sides. I would sum that up. Thank you.
Thank you so much, ma'am. Thank you so much for taking our time. It's such a nice conversation. I think it's going to be really useful for anybody who's watching this.
Thank you so much for doing this for us.